G'day everyone, Dr. Tom, Veterans Health Centre. I just want to talk about permanent impairment assessments and how we do things. It's an internal training movie, but useful for everybody. What we're talking about is permanent impairment assessment, which is the second phase. The first phase is initial liability, which used to be you just submit your claims, but now is split into two parts. So you submit your claims, either complete or what we're calling umbrella claims. And DVA will or will not issue something called a diagnostic assessment, what we're calling DIA. After those first three kind of steps there are done, and the claim's accepted or rejected, then you'll move on to permanent impairment. The culture at Veterans Health Centre is to write good PIAs and move away from just a tick and flick minimization. My only agenda is to find the impairment and have a fair process, to walk the line between DVA and the patient, to have defensibility. I want to introduce a higher standard of PIs into the culture, and have my own internal and external QI to do it properly, treat PIs with the respect it actually deserves. From my point of view, every PIA gets imaging, and this is to get the apportionment right. This is something that DVA and I still will discuss robustly. It is not for diagnosis, it is to get the apportionment right. Also, the severity, also to work out if there's any nerve root component radiculopathy with spine things. Ideally now we have all the imaging done at the first phase, the DI process, but there's a bit of legacy with patients from a few years ago where the process was different, and also PIAs that come in directly without having been through that first process with us. The overall inputs to the PI are that intake appointment, all that information from the claims that we've submitted, a whole bunch of questionnaires we'll send out to the patient, the imaging that we get, the examination that we're doing, and the risk factor assessment via the DVA form, and also another questionnaire that we send out to patients. And that RFA is like a general OCMED screen for all the defense-related occupational medicine exposures, radiation, benzenes, asbestos, solvents, that sort of thing. The document hierarchy for PIs is, the overarching tome is called the AMA5 Guide to Whole Person Impairment. That is then filtered into the DVA document, the GARP, the Guide to Assessment of Rates of Veterans' Pensions. And that has tables in it, and those tables have word pictures that define point levels for various levels of impairment. I have Word documents, so I'm not just filling out the DVA form, we are writing our own report, which is essential once you start doing it, particularly as patients will have, we've got some up to their ninth PI assessment as they come out in batches, or things change over time, or new conditions are found over the course of several submissions or years. And then you've got the DVA document, which is sent out, which is a little bit different every time, and we're translating info from the VHC Word document into that DVA document separately each time. And that document is different if it's MERCA or DIRCA. Sometimes it will assess the same conditions under both, so it's essential to have our own report in Word that we would do in Word. In the intake appointment, we'll focus with the general history, but also focusing on the parameters in the GARP. So the GARP has tables with word pictures, and we're trying to discuss the impairment in a way that matches the word pictures in the GARP. Pointless talking about random stuff when we should be talking about things that matter in the GARP. The infrastructure we have in Veterans Health Centre is we have a templates directory we use to make the reports, and then the patient library. Within the patient library, there'll be each instance, each version of the PIA will have its own folder, and we just build on those as we go to ensure that it's consistent as we travel through time. Once again, the process there, the claims and the diagnostic assessments is the first phase, and then after it's all accepted or rejected, we go into the PI assessment. It's worth noting under the new legislation after the Royal Commission, they merged those two together, so you'll be getting assessments on things that aren't accepted yet. which is makes it slightly more difficult, obviously, but we work with a process for that. The GARP is the DVA tome. The impairment is described in that. Within each section, the way the points are worked out is generally there are extra tables in some sections. Generally, the greater of functional loss or range of motion loss, whichever of those is larger, will be the points that you get for that particular section, body part, body section, with an age adjustment table and sometimes some extra impairments tables. There are some cross-pollinations between different sections in the GARP, particularly the classic one being the lumbar, thoracolumbar spine and the lower limbs, and then the cervical spine, so your neck and the upper limbs. And the nerve component of each, because you've got nerves that arise from the spine that innervate your muscles and your sensation. So the component of that, so the back can affect the lower limbs. It's meant to be sensory, but there's also a degree of biomechanical chain impairment that occurs, and same with your neck on your arms. More sensory, so sensory and motor loss, but a tiny degree of biomechanical abnormality can impact that as well. So those tables are linked. So you'll see in the lower limb tables that will include lumbar spine considerations, and in the upper limb tables that will also include cervical spine considerations. What we do when I'm taking history is I'll ask things like gait, distance limit, how you go on the gutters or curbs, whether you have difficulty on uneven terrain, how long you can stand, sit, how you go on the chairs, on examination history. Range of motion loss, that's an exam thing, but it's also worth talking about in history. Resting joint pain, you get one score for your whole body, but the biggest score for your whole body becomes your score. Whether there's any effect of the resting joint pain when you sleep, whether you've had any falls, whether there's any sciatic pain or paresthesia, so numbness. With that, there's often a lot of confusion about what the patient's knowing what sciatica is, because there's different types. There's referred pain, there's nociceptive pain, there's numbness, and there's sciatic pain. There's different types of pain that can flow into the lower limbs. There's a lot of difficulty in teasing out what's what. So the way that we do it is try and get some concordance between the history, the imaging, and the examination for those radiculopathy components, the sciatic pain and paresthesia. We want to know if there's any walking aids. We're trying to identify new conditions from the imaging and make sure we take that into account in the apportionment, which is much more important than it's given credit for, and get the apportionment right. In terms of the GARP tables, those questions translate into these word pictures. So different point levels for different word pictures of functional loss. And within the lumbar spine, you've got extra points for crush fractures of vertebrae. And these are your range of motion losses. Range of motion being interesting in that it's supposed to be active, not passive range of motion. You can assess it in different ways. Some providers will do passive range of motion and reef people through painful ranges of arc. I've had patients injured from those assessments from other providers before. So the BHC approach is an active range of motion approach, and to try and go as far as you reasonably can into that painful arc, that range of motion, like you would if you were doing things around the home or at work. You're not stopping the first instance of pain, but you're also not necessarily pushing all the way through the pain, because you wouldn't do that functionally. And then your resting joint pain gets translated into these tables. So it's about the severity of the pain, and it's about how much that affects your sleep, or whether it affects your sleep. Interestingly, for lower limbs, under Merker, you consider everything hips down as one functional unit, and then you're apportioning the impairment to the conditions within that, which is why we do our imaging so hard. Under Durker, you have to assess each condition separately. However, in order to do that, I don't know about other providers, but I need to know everything. I need to know everything to do anything, really. So I still need imaging done to make sure there's no other conditions causing that functional loss, and also get that assessment right, which is a kind of an apportion assessment as well, to get that right. The functional impairment for the lower limb It's like these word pictures. So those parameters we talked about before, how you're walking, how you go on the stairs, how you go up the chairs, whether you've got sciatic pain or not, how you go on uneven terrain, whether you're using gait aids, how you go on gutters and curbs, the speed of your walking and the style of your walking is all little parameters, and they're all the things we're assessing on the history and the examination and the imaging to get this right and to describe why we think it's that in proper detail. As you progress up to 30 points on, do you have falls? Can you get up out of the chair? Do you need a walking aid? As you progress up, you need more and more impairment to progress up through points. And for range of motion loss in the lower limbs, you can see there's different levels there for those things. How we assess those again is pretty much the same questions to the lumbar spine. So how your walking is, how far you can walk, how you go on uneven terrain, how you go on gutters, how long you can sit for, how you go on the stairs and the chairs, what's your range of motion loss, what's your resting joint pain. And with that, I want to know the minimum and maximum resting joint pain and the duty cycle of that. So if it flares up, I want to know that, and I want to know how long it's flared up for. It's an ordinary day, but resting joint pain will fluctuate. So I think an averaging element to that is also appropriate. Whether that resting joint pain interrupts your sleep is also important. How often and how much. For lower limbs, whether you have any falls, again, that sciatic pain and paresthesia to your lower limbs because you're thinking about the effects back on the legs. Walking aids, so things like walking sticks, wheelchairs, four-wheel walkers, 4-point walking stick, and again, any new imaging to get that apportionment right. The apportionment important. In terms of the neck and the arms, the upper neck, well, the neck itself is a bit more simple. It's just range of motion and resting joint pain. The functional loss just gets captured under the arms for the neck. And each arm is a separate functional unit. So while your lower limbs is one unit bilaterally, each arm is a separate unit, with your dominant arm being more important. There, your range of motion losses for your neck. And again, it's a bigger of functional loss and range of motion loss. And in terms of your upper limb range of motion, these are the stages for your upper limb range of motion. Again, with the upper limb, right and left arm are separate units, and there's more importance placed on the dominant arm. The effect of the neck is via sensory and motor loss, so that numbness, which translates to effect on your grip strength and your dexterity, so your fine motor control in your fingers. Noting there's an element of biomechanical abnormality or biomechanical chain, pain affecting the biomechanical chain, which can affect your grip strength. If your wrist hurts when you grip too much, you're not going to be able to grip more, and that's a purely localized mechanical pain. How it translates into the garb, it's all about whether you can use that limb efficiently and whether that's most of the time, some of the time, in few circumstances, which is a very subjective discussion. And things like dexterity loss, fine motor control loss, and time to fatigue. And we're doing that by asking questions like time to fatigue, how's your resting joint pain, examining range of motion loss, whether there's any numbness, dexterity loss, or grip strength loss, and we want concordance between history exam and physical examination on that, really, to make sure we cover that point properly, because that point is a very, very finessey point as well. Ideally, we've done a chart review. We need all that information before we can do a PI. Ideally, we've done that at the claims stage, but for new patients, we may not have done that. So we will do another chart review and incorporate the timeline and the history. And imaging. Image as much as possible. Anything more than max 18 months, I want to image that again. The reason I need it is for apportionment, for severity, to augment the exam and the history, specifically with the sciatica and paresthesia components, to have standards to ensure there's patient concordance and compliance, and for my own medico-legal defensibility, because my indemnity provider wants it. The PAQ is the questions I'm asking again verbally, but I'm sending a questionnaire on that and making sure that the verbal and the written answers match. And there's a lot more detail in the written answers that we get from patients. a detail issue, and it's also a time-saving issue from my point of view. And it just adds to the overall quality of what we're doing. Any difference between the written and the verbal discussion, we'll use the verbal discussion over the written discussion. And things like the management and the details of history, we verbally dictate into the notes to make sure that our discussion of management and a discussion of the history is as good as we can. The risk factor assessments, it's a general occupational medical screen from DVA. We've got our own version of that. We send that out by an RFA questionnaire, and we use our forms, which are similar to but better than DVA's forms, and simply translate that information across at the end. We'll leave the Med-in-Cap certificates out. That is best done by their usual GP and promotes the patient engaging with their normal GP as well. In terms of DVA reports, the most important thing for our reports is our Word document. That evolves and version controls with time and is consistently traveling through time in different reports that DVA sends. It's not just a one-off thing anymore. We're doing up to 9 PIA assessments under different legislations and different acts for patients, and that consistent Word document is essential, and we then translate that information from that to the DVA form, which is different every time. This way we can ensure that the work is consistent. Stability date is a big thing. It always confuses patients when we ask patients that. Stability is a concept of, does it stay roughly the same from month to month? Is the situation stable? For me, as long as if they're out of rehab, it's stable, or if they're not about to just have surgery, then it's stable. Still negative, get that? Yeah. Classic example being imminent consideration for a total knee replacement or total hip replacement, or just having had surgery and still clearly being in rehabilitation of the surgery, so you don't know where the impairment's going to end. It's not stable, and it will end up at a different point. You can have age-related decline, and that is still stable, because the natural history of every disease is that it will drift slowly over time. It's still stable. Stability is it going to imminently change in the near future? It's of mild usefulness. Sometimes there's a lot of conditions under the one thing. Stability, as long as it's after the onset date that DVA have said, it's fine. We often don't know that date because we don't get the information that we need from the requesting person. Pragmatically, it can be said to be as recent as 2 months ago, as long as it satisfies that date requirement, and that's a reasonable thing from the history that's being taken. The thing about permanency is the condition going to last? It doesn't mean forever, it just means considerable length of time. Is that going to last? Pragmatically, it means excluding things like sprains and strains, minor skin issues, bruising, that sort of stuff. Noting sprains and strains can be permanent as well, but we would need imaging to exclude other conditions, and then have to be a history of either recurrent sprains or chronic strains and sprains, which are totally things, and we're now submitting claims that differentiate acute versus chronic strains and sprains as well, because that becomes an issue here at the PI that wasn't apparent unless you're doing both sides. So we're trying to make strains and sprains go away. If there's still impairment, that's fine. We go looking for other conditions. If there's not, then we're thinking about chronic or recurrent strains and sprains. Plus, there's nomenclature, right? Syntax. So something like an AC joint dislocation can also be described as a sprain, like a TFCC in your wrist. You can call it a sprain, but really it's they're a more serious injury, still under sprains and strains, and they still become those kind of historic injuries, which are typically sprains and strains. Do you ever want to go away, or minor skin conditions that go into that? We either annotate that as resolved or not, or if there's an injury that subsumed that condition, then we would describe that new thing. For example, lumbar strain turning into spondylosis. So your spondylosis subsumes, takes over the impairment from the strain, and the impairment becomes from the spondylosis. That's an overview. Thank you.